Welcome back to the Deep Dive. Today, we're really cutting through the noise on acne.
Yeah, we're taking the latest clinical standards, the big 2024 European updates, and boiling them down for you.
Exactly. We want this to be a shortcut, giving you the practical knowledge you need based on solid evidence.
And our mission here really is to move past all the myths, the stuff everyone thinks they know about acne.
Yeah, and to focus on what the modern strategy actually is. It's shifted, hasn't it?
Completely. It's not just about zapping the spots you see today.
Right.
The real goal now is preventing new lesions from forming in the first place. And crucially, preventing scarring.
That prevention angle, that's the key takeaway right for the start.
It is. And it's so important because acne is incredibly common. Most teenagers get it to some degree. But for about, say, 15 to 20%, it's moderate or severe. It's not trivial.
And there's a whole spectrum, right? Including the really severe end.
Absolutely. We need to mention acne conglobata. It's a really severe form, thankfully less common, but more often seen in men.
And what does that look like?
You see these deep, painful lesions, double comedones, big abscesses, sometimes tunnels under the skin, fistulas, and it almost always leads to significant disfiguring scars.
Wow. So the range is huge.
Yeah.
From just a few blackheads to that.
Exactly.
So why is this condition, which, let's be honest, a lot of people still dismiss as just teenage spots, why is it treated as such a serious medical issue in these guidelines?
That gets to the core of it. It's the invisible impact. And this is, I think, maybe the most vital point for you listening.
Go.
Think about where acne usually shows up the face and when. Adolescence, a time when you're figuring out who you are socially.
Yeah, prime time for self-consciousness.
Exactly. So the psychosocial hit can be major. We're talking real impacts on self-confidence, feelings of shame, anxiety, even diagnosable depression.
And the research really highlights this disconnect, doesn't it? Between how bad the acne looks clinically and how bad the patient feels.
It's often a total mismatch. There was a Korean study, I think 2012, that found 58% of patients rated their own acne as moderate or severe.
Okay.
But when clinicians examined them objectively, only 13% actually met those clinical criteria.
So someone with objectively mild acne could be suffering just as much mentally as someone with severe physical signs.
Precisely. And there's other research, like a big UK study from '99 that found the quality of life impact of acne can be comparable.
Comparable to what?
Comparable to chronic diseases like arthritis or epilepsy or even diabetes.
That's really significant.
It is. And the takeaway for you is clear. Understanding and addressing the patient's perspective, their subjective experience, is absolutely crucial for getting them to stick with treatment. Therapy adherence, it hinges on this.
Okay, that really lands the importance. So let's unpack the why. Before we can treat it effectively, we need to understand what's actually physically going wrong in the skin. Walk us through the science.
Right. So acne is fundamentally a disorder of the pilosebaceous unit, that's the hair follicle, and its detached oil gland, the sebaceous gland.
And just mostly on the face, back, and chest.
Yep. Highest density there. And there are basically 4 key things that go wrong, usually all at once.
Okay, break it down for us. Mechanism 1.
First, you get abnormal keratinocyte shedding. The skin cells lining the follicle, the keratinocytes, they multiply too fast and they clump together. They get sticky.
So they form a blockage, like a plug.
Exactly. They clog up the follicular canal. That's step 1.
Got it. The drain's blocked. What's next?
Step 2. Increased sebum production. Sebum is the skin's natural oil. Production ramps up, mainly stimulated by androgens hormones that surge in puberty.
So more oil's being produced behind that plug.
Precisely. Though it's important to note most adult patients with acne actually have normal levels of androgens in their blood. It's more about the gland sensitivity.
Okay, blocked, poor, oil buildup. What's number 3?
Number 3 is the proliferation of Propionibacterium acnes, now often called Cutibacterium acnes or C. acnes.
Okay, the bacteria.
Yeah, it's a normal bug that lives on our skin, but it loves that clogged, oily, low oxygen environment you've just created. So its numbers explode behind the plug.
Right. And that bacterial party is what leads to the inflammation, the red spots.
That's the 4th and final step, immune and inflammatory reactions. The C. acnes bacteria release stuff. Enzymes like lipase, which breaks down the sebum into really irritating free fatty acids. Those acids, plus other signals from the bacteria, attract your body's immune cells. You get inflammation, pressure builds, the follicle wall can rupture, and boom, That's your red pimple, your pustule, sometimes deeper nodules or cysts.
So just to crystallize this for diagnosis,
Yeah.
the absolute must-have sign, the thing that tells you it's truly acne vulgaris is...
The comedo,
Yeah.
plural comedones, that's your basic blackhead or whitehead, the initial plug.
No comedones, no acne vulgaris.
Well, pretty much. All the other inflammatory stuff, the papules, pustules, nodules, they all start from that initial non-inflammatory comedo.
Okay, this is where it gets really interesting for a lot of people, I think. Separating the myths from the actual science, let's tackle the big ones people always ask about. Diet. What do the standards say?
Right. This is huge. The clinical standards are very clear. There is no convincing evidence that specific foods like chocolate or dairy or fatty foods cause or worsen acne.
Hold on. No link. After decades of everyone blaming chocolate.
The evidence just isn't there for those specific foods. Now, there is some possible weak link suggested between high glycemic index foods, think sugary drinks, white bread, fast carbs, and acne worsening.
Possible.
Yeah, some studies hint at it, but the clinical relevance, like whether cutting those things out actually makes a difference day to day, is still pretty unclear. We can't definitively point the finger at pizza or chips based on current strong evidence.
Wow. Okay, myth busted number 1. What about sunlight or tanning beds? People always say it dries out their acne.
Yeah, that's a common perception, but it's mostly cosmetic camouflage.
How so?
Well, a tan or just the redness from sun exposure can make the red inflammatory spots less obvious visually, so people feel like it's better.
But it's not actually treating the underlying problem.
No. The research shows no actual improvement in the acne process itself. Plus, sunlight can be counterproductive because, as we'll discuss, many effective acne treatments make your skin more sensitive to the sun.
Right. Photosensitivity.
Yeah, okay.
And smoking. Or makeup.
For those, the standards basically say, we don't know for sure.
Really?
Yeah. It's currently unknown if smoking or using normal, non-comedogenic cosmetics affects acne onset or severity. There isn't enough good evidence either way to make strong recommendations there. So telling someone to stop wearing makeup isn't usually evidence-based as long as it's suitable for acne-prone skin.
Okay, so if those are the myths, what are the definite proven factors that can trigger or worsen acne?
Okay, there are some clear ones. First, certain medications. Things like corticosteroids, anabolic steroids, some anti-epilepsy drugs. They're known culprits.
Right.
Second, mechanical manipulation. Picking, squeezing, scrubbing too hard, what doctors call acne excoriae. That definitely makes inflammation worse and massively increases the risk of scarring. Keep your hands off.
Good advice. What else?
Third, genetics. It plays a really big role. Studies suggest heritability is around 80%. So if your parents had bad acne, your risk is significantly higher.
Runs in families.
Makes sense. And finally, sometimes acne, especially if it starts suddenly in adult women or is severe, can be a sign of an underlying endocrine disorder.
Like PCOS.
Exactly. Polycystic ovary syndrome or sometimes Cushing's syndrome. If
Yeah.
you see acne alongside things like irregular periods or excessive hair growth, called hirsutism, then it definitely warrants looking into hormonal causes.
Okay, super helpful to clarify those factors. Let's switch gears to the treatment roadmap. You said the goal is prevention, but results take time, right? Like 4 to 8 weeks.
Yes, and that's a huge challenge, because while you're waiting weeks for the benefits to show the reduction in new spots, the side effects of treatments often kick in almost immediately, like dryness, irritation.
So people might get up too soon.
Exactly. It's an adherence nightmare, which is why explaining this timeline and managing expectations is so important in counseling patients.
Makes sense. So how does the approach change based on severity? Let's start with mild acne. Mostly comedones, maybe a few red spots.
For mild acne, the first-line approach uses topical treatments, things you put on the skin. We have 2 main options considered equally effective to start with.
Which are?
Either benzoyl peroxide, BP, usually starting with a 5% concentration, or a topical retinoid like adapalene or tretinoin.
Okay, BP or retinoid. Any quick practical tips for patients using those?
Yeah, definitely. BP is great because it's antibacterial and it helps unplug the pores, but big warning, it bleaches fabrics, pillowcases, towels, clothes. They'll get bleached spots.
Good to know. And the retinoids.
Retinoids are fantastic for preventing those initial comedones, the plugs, but they are an absolute no-go during pregnancy or breastfeeding, strictly contraindicated because they can harm the baby. They also commonly cause dryness and irritation initially.
Right. Very important warnings.
Yeah.
Okay, what if the acne is more moderate, say more inflamed spots, maybe some early scarring starting? mostly on the face.
Then we step up to combination therapy. You need to use both BP or a topical retinoid PLUS, a topical antibiotic.
Adding an antibiotic cream or lotion?
Yes, commonly clindamycin or erythromycin.
Yeah.
But here's the really crucial rule about antibiotics and acne.
Let's hear it.
To prevent bacteria developing resistance, you must limit the use of topical antibiotics to a maximum of 3 months.
Only 3 months.
Max. And this is critical. You never use topical antibiotics alone as monotherapy. Always combine them with BP or a retinoid. The BP or retinoid is the long-term maintenance treatment. The antibiotic is just a short-term boost.
Got it. Short course, always combined. Okay, moving up the scale, severe acne, lots of inflammation, maybe on the back or chest too, or that acne conglobata we mentioned.
Right. For severe acne, we usually need to go systemic, meaning medication taken by mouth. The first approach is often combining the topical BP or retinoid PLUS and oral antibiotic.
Taking antibiotic pills, which ones?
The preferred first choice is usually doxycycline, typically 100 milligrams once a day. It's convenient because you can take it with food, which helps people remember and tolerate it better.
Any specific advice for doxycycline?
Yes, it can make your skin much more sensitive to the sun photosensitivity. So patients absolutely need to use sunscreen, minimum SPF 15, ideally higher, every day while taking it.
And the duration rule for oral antibiotics?
Same hard limit, maximum 3 months, again to fight resistance. And just like with topicals, once you stop the oral antibiotic, you must continue the topical BP or retinoid long-term to keep the acne from coming back.
Okay, so that 3-month limit is a consistent theme for all antibiotic use, local or oral. Get in, reduce inflammation, get out, and rely on the non-antibiotic topicals for the long haul.
You've got it. That's the strategy to preserve antibiotic effectiveness.
Now, what happens when these standard treatments don't work, or if the acne is just incredibly severe right from the start with a high risk of scarring? That's when we hear about isotretinoin, right?
Yes, oral isotretinoin. It's often known by old brand names like Accutane or Roaccutane. It's highly, highly effective, often providing long-term remission or even a cure. It's reserved for severe nodulous cystic acne or moderate acne that hasn't responded to those other treatments we discussed, especially if it's scarring.
But it comes with significant risks. The guidelines are very strict about it.
Extremely strict. The main reason is that it is highly teratogenic.
Meaning it causes birth defects.
Yes, severe, life-altering birth defects, brain malformations like microcephaly, heart problems, facial abnormalities. The risk is incredibly high if someone becomes pregnant while taking it, or even shortly after stopping.
So there are mandatory safety programs in place.
Absolutely mandatory. In Europe and many other places, there's a formal pregnancy prevention program, PPP, or sometimes called ZPP, depending on the region. For any female patient who could become pregnant, it's non-negotiable.
What does that involve?
It requires using 2 effective forms of contraception simultaneously, usually including a barrier method like condoms starting 1 month before treatment begins, continuing throughout the entire course, and for 1 full month after the last dose.
Wow, 2 methods.
Yes. And monthly pregnancy tests are required before, during, and after treatment. Counseling about the risks is extensive. It's taken extremely seriously.
And are there other significant side effects besides the pregnancy risk?
Yes. Clinicians need to monitor blood tests for potential liver enzyme increases or changes in blood fats like triglycerides. Dryness is almost universal. Dry lips, skin, eyes. And importantly, there's been discussion and warnings about potential psychiatric side effects like depression, mood changes, and even, rarely, suicidal thoughts.
So doctors need to ask about mood.
Yes, active inquiry about mood and mental health is recommended before and during treatment. The link is complex and debated, but the potential risk means it must be monitored.
Okay. Very potent drug, very strict rules.
Yeah.
Now, before we wrap up, we absolutely need to touch on skin diversity. Does acne treatment need to be adjusted for patients with darker skin types?
Yes, this is a really critical point. Patients with darker skin phototypes, Fitzpatrick's the 4th through 6th, have a significantly higher risk of 2 specific complications from acne inflammation.
Which are?
Post-inflammatory hyperpigmentation, PIH, those persistent dark marks left after a pimple heals, and keloid formation, which is excessive, raised scarring. The risk of keloids can be up to 16 times higher in some populations with darker skin.
16 times. So the goal of preventing inflammation becomes even more critical to avoid those long-term marks and scars.
Exactly, because PIH and keloids can often be more distressing and harder to treat than the acne itself.
So how does the treatment strategy change?
Well, because some of the topical treatments, especially retinoids and sometimes DP, can cause irritation, and irritation itself can trigger PIH, the advice is often to start these agents cautiously. Maybe use a lower concentration or apply them every other day initially to build up tolerance.
Okay, start low, go slow with topicals.
Right. But also, and this is key, if those topical treatments aren't well tolerated or if the acne isn't responding quickly, clinicians should probably be less hesitant to move more rapidly towards oral medications, either the oral antibiotics or even isotretinoin,
Move faster to systemic treatment. Why?
to shut down the inflammation faster and more effectively, thereby reducing the risk of developing that stubborn PIH or potentially disfiguring keloid scarring. It's about aggressively preventing the consequences of inflammation in skin types prone to them.
That makes perfect sense. Prioritize preventing the lasting marks.
Precisely.
Okay, this has been incredibly thorough. A real deep dive into the latest standards. Just to quickly recap for you, the listener, the main goal now is preventing new spots and preventing scars.
Mm-hmm. We covered the four mechanisms: the blocked pore, the oil, the bacteria, the inflammation.
We busted some major myths. Diet, sunlight, probably not the culprits we thought they were.
Right. And the treatment is stepwise. Topicals like BP or retinoids first, then combinations with antibiotics, local or oral, but only for 3 months max. Always keeping that non-antibiotic topical going long term.
And then isotretinoin for the toughest cases, but with those absolutely critical safety measures, especially around pregnancy prevention.
Yeah.
And remembering to adjust for darker skin types to minimize PIH and keloids.
Exactly. And, if we circle all the way back to that first point we made about the patient's experience, that subjective distress often being way worse than the objective lesion count,
Yeah.
it leaves us with a really important question, I think. How can we, as clinicians, better bridge that gap? How do we make sure our treatment plans, which are based on these objective scores, also truly address the profound emotional and psychological reality of living with acne? Because sometimes that psychological burden is the deepest scar of all.